primal question here. So is it that when the patient comes to your clinic, you straight away jump to advising the patient about interventions, or there's a step ladder approach to it? So this is what I usually follow in my clinic, and this is what I preach and practice. So the first step in management, actually not only for cervical pain, for any sort of pain, comes as step one, in which the first line of management would be a medical management along with physiotherapy, if applicable. Now, when will you continue the medical management? So we should know, and we should be honest to ourselves, that the trial of medications, or let's say the trial of step one, has to be with an appropriate drug, with an appropriate dose, and for an appropriate duration. Only when the trial of medications or physiotherapy fail, that means it becomes ineffective, or let's say the pain has been effectively controlled, but in addition, the patient also develops side effects. So let's say you started the patient on carbamazepine, and the patient says that, see, after you started, I have had pain relief, but I also have a lot of, giddiness, and you see that the patient is developing hyponatremia. So that is the time you know that if you persist with it, the patient will land up in complications. So that's the time when you should advise the patient regarding step two. And herein comes your importance of the intervention pain procedures. Let's say you've tried adequate amount of interventions, and still the patient has lingering and significant amount of pain. That's the time you would advise the patient to step on to step three, which would be a surgical intervention, if at all. I mean, wherever indicated. Okay. Now it is quite understandable if the patient says that, no, see, because you're saying that intervention pain procedure might not be successful, I might want to take a leap to the step three as well. So this is something which yourself voluntarily should tell the patient. Can we mute the mic? Yeah.
Sure.
So yeah. So that is when you can tell the patient that, see, that is also a possibility with you, but it will be more logical to go in a stepwise fashion and leave the final choice upon the patient. Okay, because suppose you say that no, you should. I mean, if you insist upon thing that you should go logically, the patient might take it in a different way. Okay. So, what are the common interventions? What are the common indications that we usually come across for interventions in cervical pain? So, the most common, I think, that would be a cervical festogenic pain. That is what I usually come across. Even if the patient has had surgery many number of times, the surgeon would send the patient back to me saying that after having, and that is quite very common, because after the surgery or after say fusion, the patient, the dynamics of the movement of the joints, that changes. So there is stress upon the adjacent joint, and that leads to adjacent segment degeneration, and that can lead to festogenic pain. So that is what I usually come across. Most common condition, cervical festogenic pain. Next comes cervical radiculitis. Now, radiculopathy, I don't think I need to dwell upon this difference between radiculitis and radiculopathy. So where there is only pain, I would call that as a radiculitis. If I see that there is a significant amount of sensory and motor compromise, then I would call it a radiculopathy rather than radiculitis alone. Then I get plenty amount of headaches, and cervicogenic headache is a very common cause of headaches, which usually comes to my clinic. So these are the common causes. The uncommon ones are primary or secondary greater occipital neuralgia. Then I also get atlantoaxial joint arthritis. I have come across atlanto-occipital arthritis as well, but I do not, and I will not suggest anybody should intervene for atlanto-occipital arthritis. Then I get a lot of intracranial hypotension, for which I usually place a epidural blood patch, cervical epidural blood patch. So let me get on to the topic per se. So that is the interventions for cervical fistulogenic pain that I'm showing you as the first intervention. So what you see here right now is what is known as a true lateral view of the cervical spine. So just confirm if you can see my marker here. Vikar, can you see my marker
Yes,
here?
sir. Yes, sir. It's seen.
Okay.
Seen.
So basically, to call it a true lateral view, so there are four criteria which have to be met. So first thing that you see is that the disc is well squared out. There is no overlapping of the disc. Second thing, what you see knob-like structure, round structures over here is the transverse process. So that should be in the posterior superior quadrant. So if you divide this vertebra, so this should be a posterior superior quadrant, and there lies the transverse process. Third thing that you should see is the exact apposition of or the superimposition of the bilateral articular pillars. And fourth thing that you should see is the epidural space. So this is the epidural space, and you can see that, I mean, not the epidural space, the spinal space. So you can see that comprises at least 50% of the total spinal canal. So this is the spinal canal, and what you see here is the spinal space, which you see very, very clearly. So approximately 50% of it uh, uh, is free. So that is when you say that it is a true lateral view, and you must try to achieve this view before you get on to the intervention for cervical facetogenic pain. So now, going on further, there are two ways to address cervical facetogenic pain. One is by direct injection into the facet joints, as Dr. Nirandini has talked about. So, what she was talking about was the ultrasound approach. Here, I usually tend to use, especially for cervical spine, I tend to use fluoroscope because I'm more comfortable and confident with it. So there are two ways to go about it. One is you inject directly into the facet joints, and the second way is you can just ablate, do a radio frequency denervation by ablating the medial branches at the articular pillars. So if you notice the difference, when you are injecting into the joints, you got three injections, whereas if you are doing intervention on the medial branch, you've got four needles to be placed. So, but what are the indications of putting a needle into the facet joints? So, one and the most important is diagnostic, because see, let's say that you've done a clinical examination, you are confident that the patient is having a facetogenic pain. Still, it is always prudent to tell the patient that, see, first of all, I am going to inject you into the joints, and if you are having a positive response to the injection, then I would suggest that you go ahead with a radio frequency, because that is what is the most confirmatory diagnosis for a facetogenic pain. And second would be injection into the joint if you are expecting that it would be a inflammatory arthropathy. So the arthropathy can be of two types, either it can be degenerative or inflammatory. So whenever you're doing an intervention into the joint for inflammatory arthropathy, you would also be putting some amount of steroid there, and steroid will take care of that. Like for example, for rheumatoid arthritis patients, putting a steroid injection into the joint will be more than welcome. But then for osteoarthritis, I don't think that will be a bright idea. So it will be better to, put a diagnostic injection into the joint. If the patient responds, go ahead and do a radiofrequency denervation. So that would be a better idea than putting in a steroid for osteoarthritic cases into the facet joints. So I'll just demonstrate to you a small video of how I do a cervical facet joint injection. Just notice that what Dr. Nandini was also talking was about the mountains and valleys, right? So here what we call it as waste and the equator. So this is the equator and this is the waste. So you can call it mountain and valleys, doesn't matter. I mean, one and the same, as long as you identify or you try to understand why these wastes are caused. So these are the articular pillars, and the indentation is because of the neurovascular bundle here. So there are neurovascular bundles in the valleys, and the joint will correspond to the mountains here. Okay. So if I have to address this mountain, I'll go a mountain below and then approach, right? So this is so basically I'm trying to enter into this joint by putting in a needle at this mountain. Okay, so I'll just go ahead with the video. So this is the true lateral view, and I just a moment. I'll just explain to you one more thing. What I usually do in such cases is I go for a needle technique in which I put a hypodermic needle first, because that will give me a more control over my subsequent spinal needle which I put. And that the advantages of putting a needle in needle technique is, one is accuracy, and one is safety. Other one is safety. Okay, so this is the hypodermic needle which goes and it aligns itself with the facet joint. Then you can see the second spinal needle which is going into the joint. Okay. So that way you can very easily address the three joints simultaneously. And uh, that way, even the time taken for the procedure becomes very less. So this is what a final view will look like. Okay. Now going ahead further, uh, so that was about the facet joint injection, right? Now I'm going to talk about the facet denervation. So basically, as I had told you before, again, the mountains and the waste here. So the wastes are basically formed because of the indentation of the articular pillars by the neurovascular bundles. When at the time when the baby was inside the uterus, right? So these neurovascular bundles or structures, they cause an indentation into the articular pillars, and that is how the waste is formed. So basically, what you have to do is you have to put in a needle into the waist, and you have to try to ablate the nerve there. So there are two approaches to it. One would be the tangential approach, in which you put in a needle straight end on in this view itself, and then there will be an oblique approach, in which you take the needle a little far apart from the waist, and then you go more medially. Okay, so we'll not talk too detail in that. I don't want to confuse you guys with. So let us talk about the tangential approach, which is much easier and a safer procedure for the beginners. So if you see, this is the cervical uh, column where the intervention is going to take place, and there comes my needle. So this is for the label identification. Okay, so initially the label identification is being done with the needle, and then I just move the video a little faster. Sorry, sorry. I'm going back. Right. So that is still localizing the site. I mean, where at which level we have to do the radio frequency. And if you happen to go in this direction, that will be what will be a oblique approach. But that is not our purpose here. So what I am going to do is I'm just going to make this needle from oblique approach to a tangential approach. Let me find the cursor. Okay. So this is the tangential approach that I am undertaking right now. So I'm trying to make the needle end on. Okay, so this is the end on view. And in this view, I would want to touch the lateral border of the facial column. Okay, so just I'm trying to touch the lateral border of the facial column. You see my needle tip is still within the margin. Now I have reached the edge of the facial column, and then I'll just slip my needle past. I'll just slip my needle past. Yeah. I'll just slip my needle passed. Yeah, so this is the needle slipping past the festal column. And when I have done that, uh, I will just try to place the other needle. At this point of time, you can even take the true lateral view and verify whether your needle has passed over the festal column. Okay. But if I take the other needle as well, I will save the number of, uh, change of change of the C-arm, change of the orientation of the C-arm. Plus, I will avoid unnecessary radiations. So I'm basically now I have again slipped past the festal column beneath, and having done that, I will now take the lateral view. Okay, so this is the lateral view, and now I know that if I advance my needle further, it will fall onto the articular pillar itself. So now, and I'm in a safe position because I know that I had already slipped past the articular pillar. So keeping my needle tip medially, I will just graze over the bone till I reach the anterior border of the articular pillars. Okay. So that's the final needle in position. Now what I do is after having done that, I stimulate. So if you are going for a sensory stimulation, it has to be at 50 hertz. You should not ideally you should be getting a positive concordant pain at less than zero point 0.5 milliampere, and the motor if you're giving a motor stimulation, it should be at around 2 volts to see whether you are to rule out whether you are stimulating the ventral rami. Okay. So uh, I'm believing that everybody would know, everybody whoever is attending the session would know that the festal nerves are basically the medial branch of the dorsal ramus of the root, right? So medial branch of the dorsal ramus of the root. So when we are stimulating, when we are doing the motor stimulation, our objective is to see that we are not stimulating the ventral ramus. We are just stimulating the dorsal ramus. Okay. So, and that was about the facet denervation of the typical facet joints. Now about the third occipital nerve. See, these cervicogenic headaches, third occipital neuralgia is very one of the most common causes, and many number of times the patient will complain of the pain at the base of the skull, that is the at the occipital protuberance. Okay, so just to give you an idea about which nerve is arising from where. So GON is a typical festal nerve. Why? Because it is arising from the medial branch of the dorsal ramus of the C2 root. Whereas the lesser occipital nerve, if you see, that is actually arising from the ventral ramus. Okay. So doing a ablation of the lesser occipital nerve will be a riskier procedure, mainly because you will be going very near to the ventral ramus, right? Then about the third occipital nerve and the C3, C4 facet nerves, they arise from the C3 roots. Again, both of these are the medial branches of the dorsal ramus, but the difference is the third occipital nerve is a superficial branch of the medial branch, and the C3, 4 facet nerve is the deeper branch, right? But whenever you are doing third occipital nerve ablation, always make it a point to do the C3 deep branch denervation as well. So and there are little differences between the third occipital nerve and the rest of the facetal nerves. So there is if you see that this needle is lying just above the waist. So this is what is known as the equator. So if you look at in the lateral view, So this is the more closer picture of the AP view, just to let you realize that this is the waist and the needle is lying at the equator and little above. So if you see in the lateral view, how it will look like is that your the needle below will be at the corresponding to the base of the foramen, of the neural foramen, and the upper needle will be lying at the apex of the articular pillar here. Okay. And the textbooks also say that you can put in a third needle in between these two needles, but that will be very cumbersome a job, and you can even avoid, because even if you do radio frequency, you can very easily ablate the third occipital nerve here. Okay. All right. So that was about the cervical facet denervation, which covers the third occipital nerve, the C3, C4 facetal nerves, and the rest of the facetal nerves there. Okay. Now we are going over to the next common intervention, which is the cervical epidural injection. So here, I think everybody would know the basic anatomy. So this is uh, the spinous process, and I am going to the left side. So this would be the needle where I'll be touching the lamina, and then I'll just slip past it. Okay. So how it is going to look in the lateral view. So this is not exactly a lateral view. So this is what is known as a 50-degree contralateral view. Okay. So that is the 50-degree contralateral view in which you see that the needle has just at the spinolaminar line. Okay. So the needle tip, the two-hit tip is at the spinolaminar line. And then after having placed the needle here, what I do is I elicit the loss of resistance. And just mind you, loss of resistance is something to feel and not to demonstrate. See, many number of times whenever PGs are doing this procedure, what they will do is just to demonstrate or show to the examiners or to the guides. What they will do is they will inject a whole lot of air there. So that air, whatever you have injected, that will cause a flow void to the medication that you are giving, and the block will be patchy. So just feel for the loss of resistance. Don't try to elicit loss of resistance to your guide. Okay. So this is how you feel for the loss of resistance. I'll just demonstrate here. So you're pressurizing, and that's it. That's it. That's it. You have felt for the loss of resistance. You feel a sudden jerk on the piston, and that's it. Then you stop. Okay. And what you actually observe is that while performing the loss of resistance, this is what you will get. If you look closely at the spinolaminar line, this is what you will get. So this rarefaction is what is called a air epidurogram. So if you get a air epidurogram, you are sure that you are in the epidural space. You can see the air here. Okay, just look at it again. So this is what is the air epidurogram. Once you have seen the air epidurogram, now the time comes for you to inject the dye. Okay. And after you have inject the dye, always verify how this dye appears in AP view. So take a AP view, and you can see that there are exiting, you can see the exiting nerve roots from here, right? And these vacuoles, they might be the air vacuoles, or they might be the fat vacuoles. But if you had injected a whole lot of air here, you would see a big vacuole here, and the patient would have a patchy anesthesia. Right? So, okay, now coming on to the basics, the basis of cervicogenic headache. So, why a patient who's having a cervical problem should have a headache as well? So, if you look, this is what is known as a cervico-trigeminal complex. So, this cervico-trigeminal complex is because of the bipolar. So, this is a bipolar neuron which is situated in the trigeminal ganglion. If you remember all the DRGs, so trigeminal ganglion is also a type of DRG that consists of a bipolar nerve. So it has got one end which is going towards the V1 division, and then there is another end which is going, and that is anastomosing, or that is sort of establishing communication with the cauda, the spinal nucleus. So the cauda australis of the spinal nucleus, and then you got the unipolar neuron from the spinal nucleus, which is going down to the cervical musculature, the cervical pain generators. Okay, so whatever stimulus you get here, that gets carried forward, and then that goes to the trigeminal ganglion, and that manifests as sort of referred pain over the head. So that is the basis of the cervicogenic headache. So if you do an intervention here, if you stop the nociceptor here, the patient will have a relief in the headache as well. Okay. So uh, greater occipital nerve block is the most common intervention that you do for cervicogenic headache. So, if you remember, again, the greater occipital nerve was arising from the C2 root, and the C2 root lies hidden under this the obliquus capitis inferior here, and then it hooks around, and then that lies deeper to the plane. What Dr. Narendra was also showing, that it lies in the deeper plane in between the semispinalis capitis and the obliquus capitis inferior. Okay, then it pierces the semispinalis capitis, pierces the trapezius, and then comes up like that as the greater occipital nerve. So this is the place where you would do a what is known as a distal GON block, and this is the place where you, or even deeper to it, would be the place where you go in for a proximal greater occipital nerve block. Okay, and the most common intervention or the most easiest intervention would be a landmark guided technique in which you feel for the occipital protuberance, you feel for the mastoid process, draw a line, and trisect into three parts. So the junction between the medial 1/3 and the lateral 2/3 gives you the landmark for the greater occipital nerve for a distal GON block. So, and if you have to go for a proximal GON block, there are two ways to go about it. One is the by ultrasound guided technique, in which you try to see the greater occipital nerve in between the semispinalis capitis and the obliquus inferior capitis, like a bleb, which I'll show you in a while. And the second one would be a subcompartment injection. Okay. So, just as a case study, this was a patient who was having the this bony lesion of the atlas, and that was compressing upon the greater occipital nerve. And the patient had presented to us with greater occipital neuralgia. So, I performed a greater occipital nerve block for this patient. If you can see, so this is the this is the semispinalis capitis, and this is the inferior obliquus capitis. And in between the two planes this is the plane, facial plane in between the two muscles. And if you can see that there is a rarefaction here. So this is what is the greater occipital nerve. So that's my needle going in and towards the greater occipital nerve. And then when I finally inject my drug, you can see that the drug is very nicely, that is encircling the greater occipital nerve here, right? And similarly, you can even perform a pulse radiofrequency lesioning of the occipital nerve here. So, so that was the ultrasound guided techniques. And there is another technique which is known as subcompartmental block. So, basically, what we aim to do in this is we just go ventral to the inferior obliquus capitis, and how we do is we just touch the bone, touch the atlas of the needle in AP view first, so that we don't inadvertently enter into the spinal canal. So the C1 C2 junction, the joint, that gives a idea about the location of the nerve there. And then when you touch the bone, you just graze past it. And the moment you graze past it, that's your endpoint. Do not venture further below ventrally. And then you inject your dye. And you can see the dye is not it's not inside the spinal canal. It is just beneath and you can see the very good shadow of the inferior obliquus capitis, right? And this is the place where you would inject your medication. So that is what is the subcompartmental block. Then you got atlantoaxial joint arthropathy, for which you can give a atlantoaxial joint injection. So what you have to remember in this case is that I'll just show you the images of the atlantoaxial joint injection. So this is the needle which is going inside the atlantoaxial joint. So this joint is even more smaller than the facet joint. So hardly 0.2 ml of space is there. So you don't try to inject any dye over there. Okay. And if you can see that, look at the beautiful contour of the A joint on the right side, but look at the erosive nature of the joint here. So the point of entry. So basically, the joint has to be divided into three parts, and where you have to enter, that should be at the junction of the lateral border of the middle one third and the medial border of the lateral one third. So this is the place. Because if you go a little more lateral, you will end up encountering the vertebral artery, and if you go a little medial to it, there will be the C2 ganglion here, and further inside, that means you are inside the spinal canal. Okay. So basically, you have to remain in the lateral one third junction of the lateral one third and the medial two third of the joint, A joint. And when you inject just a very small amount, let's say 0.1 ml of dye, just to confirm that you are inside the joint, and then you inject the rest of the drug there. So, and the third condition would be this intracranial hypotension. So, many number of times, even if the patient does not have trauma, there might be a leak. So it can be uh, a leak because of the trauma, or it can be, idiopathic leak of the CSF, which occurs in the cervical space, in the cervical epidural space, from the intrathecal space to cervical epidural space, and that causes intracranial hypotension, which is defined as intracranial pressure less than 60 millimeter of Hg. Again, how you going to measure it is by doing a manometry. Okay, so then that would cause another iatrogenic leak that would be at the lumbar level, right? So, and how it manifests is, it will just be like a post-dural puncture headache. It will be a postural headache, and the patient will complain of pain when the patient is sitting or stooping forward or exerting, whatever. If there is an increase in abdominal pressure, there will be more amount of leak. The patient is going to have pain there. So, and how do you confirm? So you confirm by a CT or an MR, a myelogram. You put in some amount of dye, and then you see the dye leak. So this is, if you see on the left side, on the right side, there is no leak, but on the left side, there is a leak there of the dye. Okay. And what you do as an intervention is by putting a cervical epidural. But yes, you can definitely go ahead with a surgery, but that would be, too superfluous a procedure. I mean, what you can achieve by a cervical epidural blood patch, you will have to unnecessarily go in for a bigger surgery for that. Okay. So this is how I go about with a cervical epidural blood patch. So as against the cervical epidural injection that you have seen now, this would be more of a, I would, uh, in this case, I had taken a interlaminar approach. Okay, I mean, sorry, not interlaminar, the interspinous approach. And how I went about is I approached the, because the rent is right here. If I go through the C6, C7 space, just a moment. So if I go through C6, C7 space, I have to inject a lot of blood there. Okay, so that is why I chose to I chose to go through a higher space. So I just went through the C4, C5 space here. Okay. So that's my Tuhi going in. I felt the loss of resistance, and I injected my dye. Just little more explanation here. Okay, sorry. So if you see, when I injected my dye here, you can see that there is a posterior spread of the dye. Then you can see that there is a lateral spread also. Now one may argue that this could be, this is a intrathecal and this is not lateral spread. So that you can confirm by doing a AP view. So when I took the AP view, I saw that there is no intrathecal spread of the dye, rather it is spreading to both the sides. So that confirmed that I am in the correct epidural space. My dye is going to the lateral side, into the paraspinal gutter, paraepidural gutter, and then further on, when I inject the dye further, sorry, when I inject the dye further, I would see that my dye has gone into the anterior epidural space also. So that's my dye into the anterior epidural space. So basically, my dye was there in the posterior, my dye was there in the lateral and in the anterior epidural space. So this is actually this is after injecting the blood. Okay. So you can see that my blood has pushed the dye into the anterior epidural space. So now I know that my blood is covering the whole of the epidural space, and it is reaching the C2, C3, the where actually the rent was. Okay, so that, and the patient actually had a very good relief, and we are doing this procedure quite very often for idiopathic intracranial hypotension. So what I do in such patients is, because see, you are unsure as to how much time you are going to take to do a epidural, reach the epidural space. You cannot hurry up with it, because if you hurry up with it, there is another chance that you can end up creating a iatrogenic uh, epidural puncture. So take your time, establish it. So what I do is I take an arterial line so that I don't have to struggle with drawing a blood after I have got my space. After you got your epidural space, you cannot wait. So immediately you put in you attach your syringe to the arterial line, immediately take the sample. So here I have injected around 4 ml of blood there. Okay. So the consent has to be appropriate that way. Okay. So you have to take the consent for epidural blood patch, plus you have to take the consent for putting in an arterial line as well. Okay. So that's all from my side.